Well, good afternoon and welcome everyone to the May 28th, 2024 ZSFG JCC. Got it out right. Secretary Morowitz, will you call the roll?
Sure, I'll start with you, Commissioner Green
Present.
and Commissioner Christian.
Present.
I will now read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who were the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. We can. I'm sorry. No, please.
That's it, right?
Yes.
Okay. If you wouldn't mind calling the items.
Oh, sure.
Great.
Item 2 is the approval of the April 23rd, 2024 Zuckerberg. Actually, oh yes, that is a correct. Actually, it's the 29th, April 29th, 2024 minutes. Sorry.
Wonderful. And we have before us these minutes and they're pretty short. So if there are no additions or corrections, is there a motion to approve?
So moved.
And I will second.
And there's no public comment. So all those in favor?
Aye.
Okay, great. Thank you.
Yes.
Let's go on to item 3, an update on the psychiatric services at ZSFG. And I will pull up the presentation.
Good afternoon. Thank you, Commissioners. And it is my pleasure to come and talk with you about our psychiatric services and our psychiatric emergency service at ZSFG. My name is Mark Leary. I'm the Interim Chief of Psychiatry at ZSFG. Next slide. And just a bit of an overview of psych emergency, or PES as we call it. We're licensed for 18 patients. By regulation, patients are not supposed to stay longer than 23 hours, but of course they do based on necessity, and that's routine throughout the state. In our PES, patients are, because of our space limitations, are routinely occupied on gurneys or lounge chairs in our hallways in PES. We're the only dedicated 24/7 secure psychiatric emergency service in San Francisco. By secure, we mean locked. And we're there to provide emergency assessment and treatment for mental health, substance abuse, and triaging of medical concerns if they present to us. We focus on linking our patients to follow-up services after their visit to PES. We see both voluntary and involuntary patients. In recent years, it's been a mix of about 50-50 involuntary versus voluntary patients. And since the COVID pandemic, we have capped our census in PES. It's currently at 20 patients during the hours from 7 a.m. to 11 p.m. And then overnight, we go up to 21 when many of the patients are asleep. Next slide, please. We're very fortunate to have a multidisciplinary psychiatric staff. We have psychiatrists 24/7. We also have several psychiatric nurse practitioners. We have a full staff of psychiatric nurses and licensed psych techs. We have a ratio of one nursing staff person to 4 patients at all times. We have psychiatric social workers, which is a recent addition in recent years, and they are able to focus on placement and linkage. We also have an occupational therapist in PES who is able to provide life skills assessments for our patients and also teaches coping skills as well. And then in the recent 2 years, we've added a patient navigator who helps accompany patients to their next step when they leave PES. Next slide, please. We've been open to the city throughout the pandemic. There have been major changes in our workflows, patient flows during that time. And currently to this day, all patients who are coming for behavioral health concerns initially come to the ED. Currently, we're able to rapid triage them to PES directly. About 60% of the patients go from the ED triage right to PES. They don't actually enter the ED. And then we do the COVID testing for them over in PES. We have a psychiatrist in the ED, and this is a recent phenomenon during the pandemic. The psychiatrist in the ED sees patients there, and about 1/3 of the patients that that clinician sees are discharged directly from the ED so that they don't need to go to PES for further assessment or treatment. Next slide. So of the patients that do come to PES, about 13% in the current year of patients that we see there are admitted to an acute inpatient unit. Most of those come to our units at ZSFG. Some of them with private insurance go to other units across the city. 7% of our PES patients are admitted to the Hummingbird Psychiatric Respite. And this was, we had an expansion of those beds back in 2021. These are operated by or funded by BHS. 6% of our PES patients are transferred to the Door Urgent Care Psychiatric Clinic in Door Alley. And then the vast majority, 59% of patients are discharged with outpatient referrals. Next slide. In recent years, we've focused on linkage innovations. We've emphasized providing discharge medications, both psychotropic medications and naloxone to patients when they leave PES. The typical prescription when leaving PES is for 10 to 14 days of medications. We have the DPH Behavioral Health BEST team, which provides linkage case managers who come to PES and work with patients to help them establish a linkage to an ongoing clinic within the DPH. We've strengthened our partnerships with the help of DPH Behavioral Health with Health Right 360 and with the Salvation Army Harbor Lights facility to provide options for our patients who are leaving PES, who are dealing with substance use issues. We also refer to transitional age youth linkage, citywide linkage, and the Behavioral Health Office of Coordinated Care, which has been a great partner with PES in recent years. Next slide, please. Our citywide PES linkage team, which is part of our ZSFG psychiatry department, provides intensive case management interventions that have focused on the highest users of our PES services, and they've been very successful. The vast majority of the patients on our highest user lists in the past year or so have been able to be linked with either transitional housing or shelter and have shown subsequent reduction in their visits to PES. We have a psychiatrist working with the citywide PES linkage team that can provide medication to them on an ongoing basis until they are firmly linked to an outpatient clinic. And that's the ultimate goal, is to link them in a stable way to a DPH behavioral health clinic. Next slide. So this is a quick look at the volume of patients coming into PES on an annual basis. 2020, as you know, is a hybrid year, pre and post-pandemic, or pre-pandemic and pandemic. So that year we saw 5,385 patients. Prior to the pandemic, in 2019 and prior, we would see around 7,000 to even 8,000 patients a year in PES. Of note, we had no census cap during those years. And then over the course of the pandemic, it's been relatively stable at about 4,300 patients per year in PES. Next slide, please. This is a major change that's happened in recent years. Prior to the pandemic, and 2020 was fairly typical. The average length of stay in PES was between 18 to 23 hours. And then during the pandemic, it's dramatically increased. And in the past 3 years, it's been over 30 hours, which of course has major implications for the number of patients that we can see in PES, given that we have a fixed capacity at this point. Next slide. Then another significant change that's happened in recent years is that the percentage I mentioned earlier, that 13% of our patients that come to PS are hospitalized on an inpatient unit. That number is significantly reduced from a high of 23, almost 24% back in 2021. And pre-pandemic, the average was typically around 18 to 20. So this is a significant change. And the next slide I offer is just one of the main reasons why this is happening is just the number of patients that we have on our inpatient unit. This is a snapshot from back in March of the number of lower level of care patients, non-acute patients waiting on 7B and 7C, 32 patients in this category out of a total of 44 beds. So it's a significant majority of the beds being occupied by lower level of care patients, which has made it more and more difficult to admit patients from PES. Next slide, please. So on to some better news. We're looking ahead and we're very excited about the new PES. There are the architectural plans have been approved and permitted by the state, and the space in Building 5 has been demolished and is ready for construction. The new PS will be on the first floor of Building 5 as we are now, but it will be in the southeast corner of the building, and the door will open onto Dr. David Sanchez Way, wonderfully named street for us to be located on. The clinical space in the day room is going to be 300% larger than our current space. It's going to have open sight lines, which promote safety and security for both patients and staff. We'll have 6 private or seclusion rooms rather than the current 4 that we have. There'll be both an entry sally port and an exit sally port. Right now we just have one, so people are coming and going through the same sally port, which is a security risk. This will be much safer in that regard. We'll have an expanded triage area, which is going to provide a real sense of privacy for patients as well as safety and security that we don't have now in our current PES. And then our citywide case management team in PES will have a dedicated office space that patients will be able to access in a safe way without disturbing the flow of clinical activity in the main part of PES. Next slide. So as I mentioned, currently our census cap is at 20, given the space that we're currently occupying. We feel like we could expand that number in the new space to 24 to 28 patients. I mentioned those two numbers because the 1-to-4 ratio is significant for nursing staffing and financial aspects of that. We are planning to submit a proposal for both nursing and medical staff expansion that we want to submit in October of this year in anticipation of moving to the new space sometime in 2026. And then just one last mention or plea that the efficient utilization of PES services requires that we have better access to shelter resources for our unhoused patients 24/7. We really have very few options to discharge people after regular business hours, Monday through Friday, and very little access to shelter beds, which for a psych emergency service, given that a majority of our patients come in unhoused, is really a significant challenge for us. I think that's the last slide, yes. So I will stop there. Happy to answer any questions.
Thank you so much. Is there any public comment?
Is there any public comment in the room? There's no public comment.
Right. Commissioner Christian.
Thank you. Thank you, Dr. Leary. I don't think we've ever met, but it's nice to see you. I've heard so much about you working as I do in the DA's office around treatment courts, and it's all been positive for the decades that I've been there. So,
thanks.
yeah.
I appreciate that.
Just starting at the end, you mentioned improved access to shelter resources for people who can be leaving PES. Do, ideally, would these new shelters have some special attributes that generally shelters don't have, given that somebody, people are coming directly from the hospital?
Well, I think, I mentioned the Hummingbird psychiatric respite. That's a great kind of level of care or resource for our patients coming out of PES because it provides, there's mental health sophistication in the staff that run it, and that's really helpful to our clients. But just at a very basic level, if we just had access to the non-psychiatric shelters that exist now, if our patients could get into those shelters in a reliable way that we could count on after hours, that would be huge. That would make a significant difference. And of course, if we could get mental health sophistication in a certain number of beds or shelters, that would be great also, and would offer more flexibility and would allow us to discharge more patients in a safer way. But just at a basic level, our patients need shelter.
And do you have a sense of whether it is just the lack of beds, the total number, or is there some level of discrimination going on for people coming from PES going to shelter?
I think it's, I'm not the most qualified to speak on this, but my sense is it's availability, just availability, and that there are only a very limited number of beds that we can refer patients to from the hospital throughout the hospital, not just psychiatry, and that there's just a limited number, and we often don't get them.
Could I just, to be more specific to that point, I'm just wondering if Dr. Ehrlich could just tell the commissioners how many beds, shelter beds are specifically set aside for all the hospitals in the city every night?
There are 2 shelter beds a day for all hospitals in San Francisco. 2.
Whose idea was that?
That's what it feels like.
Okay. That is, yeah, pretty stunning. Going back toward the beginning, you talked about the census and how many people you should have and how many people you do have, and people are in the hallway in different circumstances. So I imagine you reach a point where you just can't take anybody anymore. And can you just tell me what happens at that point?
Sure. So at that point, if there are patients who are in the ZSFG ED that have been seen by our psychiatrists and identified as needing PES, or they're brought in on a 5150 by, say, the police, and it's clear they need PES, and we're at our capacity, then unfortunately they stay in the ED until we have capacity for them. And our staff work as quickly as they can to try to discharge patients in a safe and appropriate way to make room for more patients to come in. And typically during the daytime hours and the earlier evening hours, we do have capacity. As the evening goes on and the census builds up, and there are no discharge options at that, after dark, there are very few options at that point. Then those are the times, particularly in the early morning hours, between 3 a.m. and 7 or 8 a.m., that patients, there isn't room for them to come to PES, and they wait in the ED. We do have our psychiatrist in the ED who assesses patients there, can provide treatment, works with the ED staff to manage those patients. We also have the behavioral emergency response team that operates throughout the hospital, and particularly in the ED, and helps support the ED staff in taking care of the patients who are waiting to come over to PES when that happens. But we never turn away anyone from if someone shows up on our campus with a behavioral health emergency, they're brought into the ED and assessed. They're not turned away.
Thank you. Thank you for the answers, and thank you so much for your work.
Thank you.
Yeah, thank you so much. I guess my first question is, how do we solve the conundrum of shelter bed availability? Where are the decisions made, and how do we have a voice?
My understanding is the fundamental issue is that it's a separate system within city government. I mean, it's not a part of the health department. That the shelter system is not a part of the health department, and so that's
If I could just,
please.
yeah, so Dr. Leary obviously does an amazing job of running PES. And I think one of the key things that we have, the shelter bed, there are obviously not enough shelter beds in the city. So I think it's just a matter of reinforcing what the priorities need to be. I think that there's some things that we're doing. You've heard about our pilot project called BEAM, which is actually getting people off the street who want treatment and getting them a bed and a prescription for buprenorphine. So that's one place where we're working in new ways with our colleagues in other departments to, find space for people who might otherwise end up in the emergency room or hospitalized. And then I think the fact is that, we continue to explore and reinforce the importance and the great need for having spaces available, basically shelters with behavioral health support. And I think it's just a matter of, well, it's not just a matter, it's a matter of the multiple competing priorities around housing and shelter that the city is dealing with, and the fact that the shelter beds are not, the allocation of shelter beds are obviously outside the department's control.
Yes, thank you for that. I am curious about the individuals that get discharged. And, over the years, we've heard about the intensive case managements, and now we've heard about the various programs. And we had a presentation about all the various extensions of street team and so forth. But I'm curious about those people you do discharge, and especially 10 to 14 days. I mean, do we know how many of these individuals, especially those who are unhoused, actually find their way to support treatment that, again, would allow them to renew their medications? And in other words, do we have follow-up? Especially, it must be somewhat challenging for the unhoused population in particular to have follow-up, because I would think that if you have follow-up, you evolve best practices and approaches and priorities, which, in a constrained budget, of course, is so important. So what are your thoughts about that?
It's a crucial part of patient care, absolutely. And this is an area that DPH Behavioral Health is, and I mentioned the care coordination, or the Office of Coordinated Care. They're intensively involved in this and track it very carefully. And I've seen the data, which they track on a monthly basis. And the roughly at this point in the high 30% range of people that are discharged following a 5150 to PES are seen at a BHS clinic within 7 days following their 5150. And then within 30 days, it bumps up to the high 40% range of people that are seen in a BHS clinic. And those rates represent a significant incremental improvement over time. It's slow and steady, but it's definitely going upward. And I think it's larger because of the efforts of the Office of Coordinated Care at BHS.
Yeah, it sounded very exciting, the programs that we heard about and the great potential they have. The other thing I wondered is, you mentioned Health Right 360 versus the Salvation Army, and maybe I misunderstood, but I thought that in particular the Salvation Army was very much into abstinence as opposed to harm reduction, which is why I asked the question of whether, there are certain venues where individuals can go for further care that are more supportive of harm reduction approaches than others, or whether you prioritize in some way individuals that also have substance use issues, as many do, and how you allocate, and whether you see a difference in particular in success in the CBOs where these individuals end up getting further evaluation and treatment.
That's one area where I haven't seen data on outcomes, so I really can't speak to that. And I mean, that's been my impression over the years, but I think there may have been some changes in recent years. I can't speak knowledgeably about that.
Well, thank you. And I guess the last question I would have is, what makes you feel most encouraged, and where are you most discouraged in this whole area that we're trying to address with greater success?
Well, I think the thing that makes me encouraged, and I'm fundamentally feeling optimistic and positive about the changes. I think that we've never, and I've worked here a long time at the General, a long time, since the late 80s, and we've never had a more coordinated, collaborative approach to taking care of people with serious mental illness and substance use within DPH as we do now. We have really great collaboration with BHS and their programs, and that, you know, as long as we have that, and I think we can see that in the linkage to outpatient care, and that starts in PES and continues. And as long as we have that collaboration, that partnership, I think we can continue to make major changes. I think that the thing that's most discouraging is the housing resources, you know, everything from shelter to transitional housing to long-term supported housing. It's very hard to coordinate care for people that don't have housing. That's just very, very difficult to do. And so that, you know, that's the one thing that I wish we could change. Yeah.
Well, thank you for everything you've done and for your team's work in really addressing some of the biggest challenges we have for the health of all San Franciscans, which is our mission. So we're really grateful to you, and thank you for the presentation. And we'll look forward to hearing more the next time you come to speak to us.
Happy to come back and with updates, and thank you for your support, commissioners. We really appreciate it.
Our pleasure. Thank you so much.
Let's move on to item 3, the Regulatory Affairs Report.
Good afternoon, commissioners. So in terms of our regulatory affairs report, this is the May report, which references everything that occurred in the month of April, and I'll add a bit of commentary. So first up, we've got our pending survey list. You can see there that the Joint Commission Laboratory Survey is still on the list. We currently anticipate they will show up sometime in the next 4 weeks. We're hopeful. They have been known to sometimes come outside of past the window for the lab survey. So we've intentionally tried to give them some space to come. So we're hopeful that will happen. The other piece that is not listed on here because there was not activity in April, but in late March, we reported that there had been 2 complaints to CDPH, and we'd had the CMS complaint validation survey. And so we did receive the plan of correction for that approximately 12 days ago and submitted that on Friday. And what did come along with that, unfortunately, is that they did identify that it rose to condition level findings for patient rights. And consequently, there will be a revisit for them to ensure that we have implemented everything that we've stated in the plan of correction. So that again was submitted on Friday. There will be greater detail in a future written report, but we anticipate they will be coming. Again, they work on their own schedules. We're ready when they show up, but sometime in the next month. And so the team has been working closely with the Department of Psychiatry to make sure that all of those findings have been addressed. And I will say, I think my biggest takeaway from it is that there were a couple of small things related to documentation of, pain reassessment and monitoring during restraints, but there was nothing about the care. That it wasn't about the care, it was about the paperwork. And I think that's the part that every time I get kind of spun up about how many findings there are, it's like, take a step back and it's like, well, everyone is entitled to this. We need to have solid, high quality records, and we need to be giving patients every document they're entitled to. But at the same time, if we are taking good care of our patients and they are safe, that's the #1 priority. So again, we're working with that team. There will be more to come on that. Otherwise, the other surveys kind of continue to sit and linger. So we are continuing to do prep with the various departments, but that continues. On page 2, you can see our reporting from the month of April. We reported 1 event, a privacy breach, that I will just note, I believe you'll probably be hearing more about it from the larger privacy office, but it was a lost logbook that did contain, there was a number here. 755 records. So it was a large report. They've already been in contact with the Office of Civil Rights. They've reported this, and notification letters have gone out. So there is a significant investigation given the size and scope of that loss. Otherwise, I don't mean to jinx it, but I do want to continue to highlight that our HAPI number in 2023, we had reported 17 of them. And again, we've made it through 4 months of the year in this report and have not yet reported any. So just an additional shout out to that team. And then on the final page, this is the beginning of our Joint Commission monitoring data. I will describe this as the tip of the iceberg. So again, there were 85 findings that we responded to. And so this is the first month of data. We had our internal ZSFG ALCC meeting last week and I got about 50 of them through. So we will be working some magic on the paper so that I can communicate that to you in a brief yet thorough format for next month. But the 4 that I'll highlight today, since it's a one pager, is one of the condition level findings had to do with use of oxygen extension tubing that wasn't the tubing attached to the patient was being swapped, but not the extension tubing in 6G. And when we dove in further how we were going to fix the issue, they figured out that they didn't actually need the extension tubing. So it was one of those like findings that didn't have to be. But that being said, they're still doing audits to make sure that we haven't that hasn't crept back into their practice. And so for March, they were at 100%. The second section to report is from provision of care. This had to do with discharge instructions that didn't have information post-sedation. And this would be one where you can see that there's actually 3 months worth of data from February, March, and April at somewhere between 98 and 100%. And that's because they were able to implement some Epic fixes. So I think sometimes I get frustrated by how much harder it is to change something in Epic because there's so many more different layers to get through. But this would be an example where the right people were at the table and they were able to make a genuine improvement to incorporate that. And I believe we have actually genuinely improved the information we're communicating to our patients on discharge. And the last 2 that we have to report today come from NCC, which is Nursing Care Center, also known as Joint Commission's skilled nursing facility, because they have to have their own terminology for everything. So the first one is that the PICC line, the external length, wasn't being measured at each dressing change. So they have adjusted the language, done education with the staff, and they've been doing a daily audit of all residents. And so for March, they were at 100%. And the second one had to do with the care plan not being individualized. There are additional requirements in the skilled nursing setting for that level of individualization. And so they have done that. They've been doing audits, 30 per month, based on their sample size, and they were at 94% in March. So again, this is the tip of the iceberg. There will be much more to come. You'll be sick of seeing my face, but at this point, I will pause to take any questions.
Thank you. Any public comment?
Before we do that, would you mind for the record stating your name and your title?
Emma Moore, Director of Regulatory Affairs, providing the regulatory report.
Great, thank you. And is there any public comment in the room? All right, I don't see any public comment. We don't have any for this item.
All right, great. Any questions? Well, thank you so much. Amplify your shout out on the hoppies. That's really terrific because I know there's been a struggle with that and it's really amazing. Can you clarify, so what you talked about at the beginning, which is another, I guess, plan of correction, will that appear among the lower part of the iceberg?
Yes.
We're seeing
So
here?
it'll be its own iceberg. There will be 2 icebergs. One iceberg will be Joint Commission. Again, this is the beginning of that. There will be much more of it in the coming months. And in terms of the CMS validation survey related, they focused in acute psychiatry. That will be its own iceberg. So it will come this coming month in, it will show up in the plans of corrections submitted section, and then starting next month or potentially the month after, depending on how long it takes them to start collecting and reporting out the data through ALCC and PIPs. It will also continue to show up here for a number of months.
Thank you. Well, your individualized plan of care also for the 4A issues, these are things we always see at Laguna as well. And it's a big challenge. So the fact you're hitting 94% is quite impressive, as everything is that happens at ZSFG. So if there's no other questions or comments, we'll go to the next item on the agenda.
Thanks for the clarity as well. It's so easy to read.
Thank you.
Thank you. Let's move on to item 5, the CEO report.
Good afternoon, commissioners.
Hello.
Mark, Grant. I'm Susan Ehrlich, CEO at ZSFG. So as usual, I have my narrative report and data, and I'll go through the narrative. I'll highlight some parts of the narrative for you. So the first couple of pages focus on equity. I'm really proud of the work we do on equity and all of the forms that it takes. The first item has to do with our equity champions. And it's really nice to highlight the really diverse work that this group of individuals does to promote equity throughout the hospital. Next month, we'll tell you about our awards ceremony, which includes some of the work that this group does and more. The second item has to do with counseling. We celebrated Counseling Awareness Month, and there is so much counseling that happens at the ZSFG campus. Some of it Dr. Leary mentioned, the BERT team, psychiatric emergency service, and then in addition, there's the OTOP program and the addiction care team. And that's just a tiny slice of the work that our counselors do. I really can't imagine providing care on our campus without having the benefit of counselors. So I really want to celebrate the work that they do. It's challenging and it's essential. I want to talk about safety also. This milestone is really tremendous. So in just a little over a year since our SAFE system was implemented, there were 10,000 SAFE reports filed. And to me, what that is an incredible demonstration of is the culture of safety that we have at the hospital. It means that people are being vigilant about their environment and reporting all of these events so that we have the opportunity to follow up on them and improve care to our patients and improve the care environment that we're providing. So I think this is really incredible. And I want to make sure that you see that and celebrate that along with me. We have a new director of health information management, Mary Edith Holloway. She is actually a leader for the whole network, and it's really nice to have her. She does some really important work for us, not just about documenting who our patients are, but there's a lot about coding and charge capture and clinical documentation integrity. All of this is important, really essential to the work that we do. I think I'll stop there. We have a lot here, and I'm happy to take any questions you have on the narrative before I move to the data.
And we'll do public comment at the end of the whole report.
Right.
No questions.
I just have one question. You obviously have this incredible program for workplace violence, and were there any conclusions from all these SAFE reports that led you in a different direction or caused you to add other items for observation and data collection and so forth? Were there any surprises as you reviewed the SAFE reports?
I think what is most illuminating about the SAFE reports is the environment into which they are considered. Our workplace violence committee, our assault governance committees, all of the SAFE data advises what happens there. And what is great about this is that it gives us the opportunity to understand what's happening best on campus and to refer it to the various committees and groups that we have that are considering, what's happening on campus. One of the things that we'll talk about later when we look at the workplace violence data, we're seeing an uptick in verbal abuse, which, doesn't make the numbers look particularly good, but in my mind, it's a really important thing because it is the type of abuse that happens that people just tend to absorb without taking action on it. So the more we can have a place where everyone feels comfortable and feels not just comfortable, but is willing to report, that to me is what's important about continually expanding our understanding of what's happening with workplace violence.
Thank you.
Good question. So what is the outcome of a report under SAFE? So what happens, there's the examination of the issue, and then is the person who made the report, if it's not anonymous, is there some kind of response?
Yeah, that was one of the great things about the SAFE report system is that it provided a feedback loop. If you're reporting and identifying yourself, you're reporting into a bucket, right? That bucket gets referred to a defined set of individuals, one of whom has the responsibility for following up on the report and resolving it. And then that information gets fed back to the person. And when you file a safe report, as the filer, you can check in on the progress of it at any time. So it's a vast improvement from the system that we had before.
Is there a compilation of reports in certain categories so that, you know, at the end of the year or the quarter or whatever, someone can go and look and see what's?
Yes. Emma, you're close. Did Emily MLS? Twice. There you go.
Okay,
Yes. Thank you, Will.
thank you.
Great.
Okay. So I'll move on to the data.
Susan?
Yes. Did you have? Okay. All right, emergency department. So you can see that we just keep getting busier and busier. We are clearly above and beyond. We're at the point that we were at pre-pandemic, and we continue to go up. And I think you probably understand also that as our diversion numbers go down, that leads to the volume going up. And we want to be available to the community for people who have urgent and emergent issues. Admissions basically follow the volume coming into the ED. So leave without being seen and leave without being triaged, there has been a tremendous amount of improvement work going here. I think I described to you some months back that we had a whole value stream event. We had extensive involvement from not just staff in the ED, but also patients and getting patient feedback. You can see that our improvement here has stalled, and there are some specific reasons for that. I think it's often the case with any improvement effort that you'll make an initial improvement, you'll find new things, and then you need to redouble down on those things. So we want to get down to 2. We intend to get down to 3 and then 2. The 3 is our target, and we're just stalled at this point. There are some issues around how we address patients who come into triage and delivering meds to those patients, and how that fits in with our nursing standards, our nursing ratios. So we're in the process of resolving that now. I will say that it is very hard for the team to do really well here because of all the boarding we have. And the boarding is a result of the lower levels that we have. I know you all understand this dynamic. So, but they're still really working hard on this topic. Diversion, you can see that we're doing really well, and we will be right around the same target in May. We're almost done with May now. You had a question about percentages. This is the percent of time we are on diversion. We don't have a count of the number of ambulances we turn away, but the number of ambulances that come, it's usually in the 30s to 50s every day. But this is the percent of time we're on diversion. And this is measured by, it's not just, we don't have these data. Every hospital in the city has these data. They're looked at very carefully by EMSA, the Emergency Medical Services Agency. It's a big topic of discussion right now. So that we're doing really well there. I would say that one of the really important interventions we've made here is just having regular meetings with our charge nurses. So our director, manager, charge nurses are very focused on this issue. So it's, we're just making sure that it's a regular topic of discussion. And it's surprising to see that just that in and of itself can lead to this type of improvement, but it's been working for us so far. Any questions about those? Because I know both those topics are big ones. I'll just pause. Okay. Transfers from ED to urgent care, there is definitely a solid partnership there. This line is pretty stable. We have been talking at the last couple of meetings about the transfers from urgent care to the emergency department. And I think here what we see is getting back down to baseline by a focus on standard work. and having more regular staffing there, so we don't have as much variation in practices. Just spoke a lot about PES, and I'm not sure we need to say more here. Mark just said it all. But you do know that we're licensed for 18 and then we flex up to 20 and 21, and that's pretty much what's driving these numbers there. We've seen an increase and then a slight drop in the daily admissions. That really is limited by the space that we have available on the inpatient side. And there are two things that are responsible for the increase in daily discharges to the door urgent care. One is that they've just been talking more. The PES team has reached out to door urgent care. They've let them know that in the past there was a lot of no, and they're working with them to try to get more frequently to yes, and that has been successful. There's also an acknowledgement that door urgent care had a hard time staffing during COVID and post-COVID, and that's recovering to some degree. And then I think the next most notable thing I'd like to cover is just the 4A census is the next one on page 24. So you notice that the 4A census is lower. I mentioned this last time. This continues. The 4A census has to be lower because we're doing seismic construction on 4A. So 26 is really the limit at this point. We will have to go lower than that later in the summer. And so we're trying to figure out contingency plans, but we'll need to go to 15 or lower later in the summer, which, as you know, we can really not, that's going to be challenging, but we're working on contingency plans at this point. And then lower level of care, average daily census on med-surg and on psychiatry is, it's just not a good circumstance, and that it hasn't really changed that much. There's not a lot more I can say about that at this point. Workplace violence, we touched on a little bit. You can see that our total events went up. There is an increase in the verbal reports, which is good. We had a spike, you can see, in March for events with violence. What I'm learning is that these spikes are often because of one or two patients on a unit who will have multiple events. I think we're continuing to work on our standard work for med-surg, which is where we're seeing an increased number of assaults, which is probably a combination of reporting as well as events. And our BERT team is working with them on that. It's different than the work they're doing in the emergency department, where they can really be present at all times. With med-surg, the focus is really more on creating care plans for individual patients in different places there. And I think with that, I'll stop and see what questions you have.
Any public comment?
Is there any public comment in the room? No public comment.
Any questions?
No questions.
Yeah, I thank you so much for the report. I had one. As we look at the days that are decertified, where in our financials do we account for that loss? I mean, it's lost revenue. Is it on revenue side,
Right.
expense side? Where do we account for that?
Right. So, sorry, that was one of your questions. It's not accounted for specifically, but what it means is that we're not getting payments from insurance, Medicare, Medi-Cal, or private insurance. And so essentially that means it's going to be covered by general fund unless it's partially covered by one of our supplemental revenue sources.
So we don't like allocate a certain amount per day the way they would pay us a certain amount per day, or take what we should have gotten if we were getting. So we don't track. Okay, but I was just really curious because, as we look at these numbers rising, just wondered how it all fits into our analysis of budget projections and so forth.
Right. The more patients we have who are not decertified, the better we do with revenue.
Yeah, we don't assign a number on the expense side. Okay, that's all I really wanted to know. Great.
Oh, sure.
So I just, with the commissioner's permission, I just wanted to add a addenda to the addendum, addendum to the Chief Executive Officer's report, because our Chief Executive Officer will not mention this to you in her report, but she was honored as, I'm going to put my glasses on and read it from my phone so I get it exactly right, as one of the Bay Area's most admired CEOs by the San Francisco Business Times. And she was recognized for and honored for her vision, values, performance, and what it takes to lead. So just wanted to highlight that because the Chief Executive Officer will not. And I think it's a real tribute to her and her leadership of her team and of the hospital to go to President Green's point of what an outstanding hospital it is.
Thank you.
It's really extraordinary. Congratulations.
Thank you very much. I really appreciate it. I say this all the time. It's really my privilege to lead this incredible place.
So well deserved.
Thank you.
You are exemplary. You're iconic. You really are. There are so many people trying to emulate you. And every time I see you manage something in a certain way in the way you express yourself, I go right to Hamla and give her a suggestion. She's
I'm sure she really
plagiarizing you.
appreciates that.
But seriously, I mean, you are so remarkable in the way you lead and the way you present and the way you show such really genuine gratitude that I think all of us and everyone in this room has some kind of leadership role. I know we all carry you as an example, and I certainly tried to, express my inner Susan Ehrlich as much as I can whenever possible. So we really admire you and congratulations.
I'm deeply grateful. Thank you.
Fortunate to have you.
Thank you. Thank you, Brad.
No more blushing. It's all over. Item 6 is the hiring and vacancy report.
But what about Bert? Is that part of it?
Oh, that's all part of the, it's usually just the
For
CEO.
information.
Yes, it's usually that, if you'd like to ask about that, you're welcome to.
Please. Yeah, I was just, I thought these reports were terrific, and we all know how successful the BERT team has been, and just what incredible potential it has in so many ways. And I know we're trying to echo that at Laguna Honda as well, and I think they're finding very similar positive outcomes with the BERT team. I just had one quick question about it, which is that when we look at the demographic of the individuals, I was sort of struck on one of these, and I'm not sure which one. Oh, I know it was the I think wasn't the ED one, it was the in-house.
Yeah.
At the number of relatively older people
Yeah.
that you've had to trigger the BERT team. So I wondered if there were any characteristics of those particular individuals that represented. I mean, it seems that somebody, certainly, some of these people may be physically frail. And I was wondering, as you talked about verbal abuse and so forth, whether there was any particular difference in what triggered the calls to BERT for different, especially different age demographics.
Yes. I don't think BERT keeps specific data on what you asked. And we know that the older you are, the more at risk you are for having cognitive issues
Yeah.
in the hospital. And we know from, just anecdotally from the reports that a lot of them are because people, are experiencing cognitive issues while they're in the hospital. Delirium, that's a known documented risk for older people. So that definitely plays a role. I can drill down with the team a little bit more about how they account for delirium or dementia in the hospital versus other things.
I just thought it was interesting, and thank you again for this whole concept, which came directly from, I know, the leadership at the General, and it's just such an innovation with such quickly proven benefit that hopefully other institutions will see what you're doing and take up the same kind of a program because it's clearly so incredibly efficacious and might be useful in our CBOs and in many other, organizations that we affiliate with as well. So thanks. I was just curious about that.
Yeah, I really want to applaud Joan Torres, who is the nurse manager who got this whole program off the ground. I think you saw her and heard from her. She's really remarkable. And the success of this program is obviously the whole team, and her leadership has been exceptional.
Wow, thank you. All right, now we'll go.
The HR report. Thank you.
Good afternoon, Commissioners, Dr. Colfax, Mark. We are very happy to report that the total hospital vacancies has decreased to 6.91% as of April, and we were at 8.23% in March. We hired a total of 81 employees in April in various classifications and had 5 separations during the same period of time with 3 retirements. And our RN vacancy rate is down to 2%. And it's been a real partnership between nursing leadership, HR, and our recruiting team. Just it's been a partnership all the way around to try to look for ways to bring our vacancy rate down. We hired a total of 48 nurses at ZSFG, and that includes our reassignments. Some of the things that we're working on is, as I think you guys probably recall, last year we had a project to map the hiring process. And as a result of that, the Controller's Office analyzed all of that data. And basically what they came away with was, I think they noted 173 hiring steps from beginning to end. And about 50% of that are legally required steps. So there's not a lot of leeway to look at ways of improving some of those steps and minimizing the timeline. And they also looked at just the amount of effort it would take to make significant impact. And they looked at, there was basically not a lot of projects that could be taken on that would be minimal effort for a big impact. They would all require a lot of effort for a big impact. So based on that, and with HR leadership, it was determined that the onboarding process was going to be selected for process improvement. So the Controller's Office will be working with our onboarding supervisors and onboarders to really look at what that process looks like and just see where they're going to make recommendations for improvement in that process. It hasn't been reviewed in quite a while, so I think it's a good place to look for improvements. We're also, as part of our strategic hiring plan, we're continuing our monthly hiring process, which really, I think, has contributed a lot towards bringing down our vacancy rate. So doing the reassignment and eligible list selection simultaneously. We're also working with nursing leadership to trigger those hiring processes to start earlier. So knowing if there's a retirement coming, if there's a reassignment, what will create a vacancy so that we can get ahead of it and start that selection process sooner rather than later. And we continue to have meetings all the time to see how we can improve. So we're meeting with the executive team and program managers to review all of the hiring plans. As far as vacancies, the emergency care is at 7.0 FTE. They've made 7 selections, and you can see there's different start work dates from this pay period all the way through August. Some of those are because of the training programs actually don't start until August, so we have delayed start work dates. Critical care unit has 1.8 FTE vacancies with 2 selections made with target start work dates, again, this pay period, and then in June. Med-Surg, they had 3.95 FTE vacancies, and they are making selections now. In fact, as of Friday, we received some of their selections. The OR unit has a 1.0 FTE, and they've made the selection, and their start work date is in this pay period. The emergency care training program is the one that's starting up in August. We're also working with nursing leadership to identify what the training program dates will look like. They want to make sure they're targeting when the school graduation dates are out. And so, we're working to see when that next list will be adopted. And our core hiring team for non-RNs has done a great job of hiring into other job classes. So as you can see, we've hired 1 patient care assistant, 8 hospital eligibility workers, an 0923 manager 2, an 0941 manager 6, and a 2322 nurse manager. So just a lot of progress in terms of hiring. I know that you had some questions. Let me just pull them up really quick. So you asked, beyond the incredible progress made in the hiring practices, has the pandemic's end had an impact on the lower vacancy rates? More grads, more RNs returning to the workforce. And we don't really have data to be able to show, specifically what it looked like before COVID and then after COVID. But I think what has made a big impact has been the consolidation of the lists. Before, we had 19 different job ads that you had to apply to 19 different ads if you wanted to work in any of those areas. Now it's one job ad and one application, and hiring managers across the board can look at your application. I also think that the monthly hiring has helped the vacancy rate as well. And I did talk to our recruiters, and while they're saying that there's definitely a lot of interest in nursing jobs, and specifically DPH nursing, they're seeing a lot of hits, on the job posting, but just not a lot of applications. So on average, we're getting about 140 new candidates added to the eligible list since the beginning of this year. But again, compared to, the number of nurses that have left just the profession in general, have retired or are looking for non-bedside positions, I think we're still in the same place. We might be looking at a turning point, but overall, there's still a lot of interest, just not a lot of applications. And then for the other question, you said, congratulations on the low vacancy rate. If the unions ratify the contract, which provides RNs with a solid incremental pay increase, will that close the rates more? I think it definitely will make us more attractive. But like I said, I think in general, nurses are able to have a lot more selection, right? They can pretty much go anywhere they want. And so I think it's just a matter of making sure that we are targeting those who may be like new grads who are completing their clinical rotations at DPH, whether it's at Zuckerberg or Laguna Honda. It's targeting them, and they're really more interested in coming somewhere where they get to know the people, get to know the environment. So it's really targeting those who have had some sort of interaction with us to get them through the door. But definitely the pay will be a good be attractive to nurses. I don't know if you have other questions.
Thank you. Any public comment?
There's everyone in the room is staff, and there's no one remotely, so no public comment.
Any questions?
Yeah, thank you for the presentation. It's really encouraging. Congratulations on the work. Am I mistaken in, I think I remember that there had been inquiries made to people to whom offers were made, but they didn't accept, about why they didn't accept an offer. Is that not right?
I don't think we're collecting that data in a standardized way. We're starting to, but we don't have all of that data now. I mean, I can think of a few times when there's been some declines, and that might be due to, again, location. They might be really far away, and they just didn't realize, what it took to get here. I think others might be more interested in specific areas, and they're just, the positions in those areas aren't available. So I don't think we have solid data on that, but we can definitely try to come back with some of that information if we have it.
Well, if it's useful to you, I certainly don't want you to try to gather something that's not really going to be helpful to you.
Yeah, I think we have heard those questions before, so I think that's useful information. We'll start to collect that information.
Is there any way on the website, when you see that a lot of people are clicking, but a lot of, not very many people relatively are applying, is there any way to ask people, like, why did you choose not to apply? Or is that not the way it's set up?
That's a good question. I'm not on the recruiting end, so I'm not sure if they're able to gather that information, if they're able to, to reply back to that person, just say, hey, give us a little bit of feedback. So I don't know. I'll have to ask the recruiters if that's an option for them to try to find out why they're not applying.
Thank you.
Yeah, well, I still remember sitting in Carr Auditorium where it was like more than 23 months to go through your 183 steps, and the kind of progress that's been made is really very remarkable. So every time we hear it, we're so pleased. I did have one question, which is, do we have, I have student nurses in every case I do, at least in labor and delivery at CPMC. And I'm wondering, do we have a kind of a toehold in every school of nursing in the Bay Area so that we have, as you said, that connection? So individuals who are graduating will feel like they're coming into an environment they've experienced before. And I think Sutter has been very aggressive in that regard. And I'm just wondering, because I see badges from different nursing schools, they have that they're students and then the school. I'm wondering if we've done the same at the general.
Yeah, I'm aware of, we do have contracts with specific schools that come in and do their clinical rotations with us. But I think we're working on making sure that we have, we're trying to reach as many schools as possible. We have a RN strategist. And so she's definitely working on establishing those relationships in addition to, our nursing leadership who have the daily connection with those schools. But we do have some agreements in place, with schools around here to be able to have those students come in and do their rotations with us. Yeah.
Well, I think we see a lot from Samuel Meriden from Dominican in particular, I think at our place, and they're wonderful. They're appropriate and they're enthusiastic, and you can, you see them all huddled there with their little white uniforms in the lobby getting ready. And they usually also come with at our place, they have instructors that come with them. One instructor, I think they're just showing them, like how to press an elevator button and things like that, gloves and so forth. But they really, you feel so optimistic about, the future nurses when you interact with this group of young students. So I was just curious to know whether we were able to.
Yeah, we have, I don't know how many schools we have. I don't know if anyone here knows how many, but we definitely have established relationships with quite a number of schools. But they definitely, once they're on campus and get to meet the staff and get to see the daily routines, I think they really come back and tell us they love it. They'd love to work here. And so we're trying to find ways to make sure that we bring them in once they've had their rotation.
Great, thank you.
Thank you.
All right, let's move on to the medical staff report, which looks very brief.
Good afternoon, Commissioners. Gabe Ortiz, Chief of Staff and Chief Medical Officer. I have no report for this session. We are in the process of aligning our service reports so that standardized privileges and our standardized procedures and our privileges align with our service reports. And so we're in the process of tweaking that. And so for today, it's a very short report, kind of no specific reports, service report, nor kind of rules or regs for review today.
Thank you. Guess there's no public comment on.
No public comment.
Non-items.
Short. Item 8 is other business. There's no
I have a pressing question. How are you?
Great. Thank you. I'm great. Thank you for asking. I think kind of just acknowledging Susan and her recent award. It's just been, she's made it the transition a really smooth one for me into the Chief Medical Officer role. And the award is very well deserved. I think that I am just honored to be part of the executive team at ZSFG, and I'm really excited to be contributing to the mission that we strive for.
Great to hear. Glad you're well.
Thank you.
And do you have to top the performance of last year at the dinner tomorrow night?
There's no way I can top last.
That's a high bar, a very high bar.
That is a high bar. Agreed.
Great.
All right, thank you. Item 9 is public comment. We have no public comment in the room or remotely, so we can move on to a consideration for a closed session, item 10.
All right, is there a motion to move to closed session?
So moved.
And I will second that.
All those in favor?
Aye.
All right, great. Well, would someone mind closing the back door and give me 30 seconds to take us into the closed room, and I'll let you know. We are back in open session. Commissioners, please consider motion to disclose or not disclose discussions held in closed session.
I move that we not disclose discussions held in the closed session.
I second it.
All those in favor?
Aye.
Great. And now consideration for adjournment.
So moved.
Second?
All those in favor?
Aye.
Aye.
Thank you, everybody.
See you tomorrow night.